Thank you.
I've tried to take the question from the audience, and this year I'm doing it a little bit differently, talking a little bit more about the impact of quality of life, because people with Parkinson's often come in discussing the tremors, the slowness, the walking difficulty, and a large part of what affects the quality of life may actually not be the symptoms that they may be having. So I'm going to talk a little bit more about some of these other issues that we talk about. But I'm also going to, in general, talk a little bit about Parkinson's disease, because every year we have a significant number of people who come in who have never attended a program before. So I kind of try to give a background of what Parkinson's disease is and what is different from Parkinsonism. So when we talk about Parkinson's disease, we are basically talking that there are certain cells in the brain that are slowly dying, and that's what is causing the symptoms. So it's a brain disorder that's occurring. Patients can have symptoms of tremor, slowness, stiffness, and balance difficulty in later stages of the disease.
Can you hear this? Well, okay. I'll just hold this on here then. So one of the issues people come in and have a diagnosis of Parkinson's, and when they come in, I try to tell them they have symptoms of Parkinson's, but they may not have true Parkinson's disease. And the challenge here is anyone who has slowness, tremors, walking difficulty, balance difficulties, has symptoms of Parkinsonism. Well, the most common cause is Parkinson's disease. And looking at the clinic that one might be going to, it may vary anywhere from 75 to 85% of the cases of Parkinsonism actually have Parkinson's disease. However, a small percentage of them have other forms of Parkinsonism. Does not mean that if someone has a different form of Parkinsonism, we are going to have different group of medications or we're going to use different group of drugs. We still have the same treatment options available, but in the long run, it may make some difference if a patient has what we say true Parkinson's disease and one of the other forms of Parkinsonism. So when we talk someone has one of the other or atypical forms of Parkinsonism, one of our biggest concerns is what we say multiple system atrophy. But multiple system atrophy, like the name suggests, there are multiple different areas in the brain that may be affected. And so people may have other issues come on earlier, maybe have much faster these issues going on, as opposed to Parkinson's disease, where everything moves much, much more slowly. The other one is progressive supranuclear palsy. Early on in the disease course, we may often mistake these different forms of Parkinsonism, and at times we may also think this is Parkinson's disease. So someone may have a diagnosis of Parkinson's disease by another neurologist. They may come in 2 years and I may say, you know what, I really suspect you have PSP or progressive supranuclear palsy. It's not that the neurologist may have missed the diagnosis 2 years ago. It may be at that stage they really had just some slowness, some degree of stiffness, and even I may not have made the correct diagnosis at that stage. But as the disease progresses, these different forms of Parkinsonism may become more obvious, and it's easier for us to differentiate a multiple system atrophy from Parkinson's disease, a PSP for Parkinson's disease, or even other conditions like corticobasal degeneration, where they have a lot more symptoms on one side of the body. They may have what we call dystonic symptoms that occur in the body. So there are other features that may help us differentiate from true Parkinson's disease. One of the other things is Lewy body dementia. And we at times struggle with Lewy body dementia because we, being at academic centers, like to use the correct definition of Lewy body dementia, where the Parkinson's and memory issues begin within a year or so of one another. So if someone has Parkinson's symptoms and 3 years later develops memory issues, we call that patient having Parkinson's disease with dementia because the memory issues occurred 3 years afterwards. However, often neurologists and psychiatrists may call Lewy body dementia no matter at what stage it occurs, whether it occurred 3 years later, whether it occurred a year later, or 10 years later. Again, clinically, in the clinic, it doesn't really change our treatment on how we would treat it. And we are trying to rethink of the definition again and saying, well, maybe if both are there, we should just be calling it Lewy body dementia, because pathologically, in other words, when you actually look in the brain, the changes may be pretty similar at the end, that clinically it may not make that big a difference whether we say someone has Parkinson's disease with dementia or Lewy body dementia. However, when we do research studies, this change may be more important than what happens in the clinic. I'm just going to talk a couple of other conditions before we move on. One is drug-induced Parkinsonism. We see less and less cases of drug-induced Parkinsonism, but if someone is on one of the medications like what is used for schizophrenia that we call neuroleptics, or medications that are used for stomach disorders like metoclopropamide, or also known as Reglan, patients can develop symptoms very much like Parkinson's disease. And the only way we might be able to differentiate that is by discontinuing the medication that may be causing it. We have a special scan called the DAT scan now. In certain patients, that may help us differentiate whether this is from the medications itself or whether they also have the disease plus the medications making it worse. Essential tremor is a condition where only a tremor is there. They don't have any slowness, don't have any walking difficulty, don't have any stiffness. So if someone only purely has tremors, it may be essential tremors. Essential tremor is much more when you have a tremor while you're doing something, like bringing a cup of coffee or something and trying to drink it, as opposed to Parkinson's disease, where most often the tremor is when you're just relaxed and holding the hand in a resting position. The other one is normal pressure hydrocephalus. A few years ago, there was this big deal that every Parkinson's patient could have normal pressure hydrocephalus. And what that basically means is there is fluid in the brain that may be pushing the brain a little bit. So when we do a scan, like a CAT scan or an MRI, it shows that the ventricles are enlarged. Now, you can have enlarged ventricles when there is extra fluid, or if there is shrinkage of the brain, it can also at times look like the ventricles are enlarged. So that's an important differentiation that we have to make, whether this is indeed normal pressure hydrocephalus or it is more brain atrophy occurring. And again, doing a scan like a CT or an MRI might help us differentiate those conditions. We used to talk about Parkinson's disease, at least when I was a medical student, that it involved the area of the brain deep in here called the substantia nigra. So this is the part we used to believe here the cells were dying, they were producing less dopamine, and that was resulting in the symptoms of Parkinson's disease. Here is to show you the cut in a normal brain here and one with Parkinson's disease. And here, as you notice, the blackness of it is reduced. Here, looking under the microscope, you see in a normal brain, there are many more cells as opposed to Parkinson's disease, where you see there are fewer and fewer cells that are present. And finally, we often talk about pathologically, or when it is seen under the microscope, the brain should have Lewy bodies. And this is what we call Lewy body right here. And this is a Lewy body, and that we used to consider that a person has to have a Lewy body when we examine it pathologically to say this indeed was true Parkinson's disease and not one of the other forms of Parkinsonism. But now with certain genes being discovered, there are certain genetic disorders which can very much look like Parkinson's disease, but at times may not have Lewy bodies per se. Well, we kind of have tried to rethink of how brain that may be occurring in Parkinson's disease. And one of the hypotheses is that it may actually start right at the bottom of the brain or the brain stem, and then kind of the disease going up. Dr. Tanner kind of brought up the issue that before a patient actually starts developing the tremor, the slowness, the walking difficulty, we are beginning to notice some of the premotor symptoms. For example, loss of smell, constipation, sleep disorders like enacting the dreams in sleep. Those might be occurring before the tremor and slowness occurs, and we believe that may be occurring more because the disease has not reached that part of the brain where we actually see the slowness, the stiffness occurring. And as disease further progresses, more brain is involved, and that's where some of the memory issues may be beginning. So that being one of the differentiations we have looked over the years, that maybe it's not just one tiny area of the brain that is affected. Maybe over years there are more areas of the brains being affected, and that's why you're seeing more than just the tremor, the slowness and stiffness. And that's why it is important not only to focus on the tremor and slowness part, but also some of the other symptoms that are also occurring. So today, when we try to differentiate the symptoms of Parkinson's disease, we can look at that as what we call premotor, those that occur before the motor part of the symptoms that occur. Then we have the motor symptoms itself, and finally the non-motor symptoms that occur. The premotor, as we have mentioned earlier, it's the constipation, the depression, the loss of smell, and then acting out the dreams. Those are kind of the premotor symptoms that occur before the actual motor symptoms occur. The non-motor symptoms can occur pretty much at any stage of the disease, but they're also very important when we start treating a patient per se. When you look at the chemicals that are involved in Parkinson's disease, again, we keep talking about dopamine as the most important chemical that's involved in Parkinson's disease. That's why any medications we have used for Parkinson's disease in some way or form have acted on the dopamine system. We have been very successful using medications that are replacing dopamine in the brain. That's why you see improvement in the tremor, improvement in slowness, improvement in walking. However, some of the symptoms, in spite of replacing dopamine, may not improve. For example, balance difficulties later on in the disease, freezing of the gait, falling, they may not improve no matter how much more medications we give. And maybe it might be related to some of the non-dopamine systems that are involved. We also know that other chemicals like serotonin and noradrenaline are involved, which result in depression and anxiety being an issue with Parkinson's. So the depression in Parkinson's is just not related to, okay, you found out someone has Parkinson's disease, we have a right to be depressed, so that's why someone is depressed. Well, things are also happening in the brain. There are chemicals that are also being involved in the brain. And at times, we also need to replace those chemicals in addition to using psychotherapy, which is also equally important, and in some patients might even be more important. The memory issues occur from a different chemical altogether, acetylcholine. And that's why you use medications to actually act on the fourth neurotransmitter in the brain or the fourth chemical in the brain. That's why at times patients are taking multiple medications, working on different areas of the brain, different chemicals in the brain, because we are trying to help different symptoms with the disease. When we talk about Parkinson's symptoms, it is very important to differentiate that it is not the medications that are causing some of these side effects. That may look like maybe the disease itself may be causing the issue. For example, sleepiness. Patients being sleepy during the day could be due to multiple reasons. It could just be because they have Parkinson's disease, but it could also be a lot of medications may be causing the sleepiness. Maybe the boredom of not having to do anything during the day may be causing the sleepiness. Or other medications that they are taking, they could also be causing sleepiness. Same thing with the nausea. That occurs more with the medications. I often seeing people come to the clinic being nauseated, otherwise doing well. Well, the first thing we need to decide, is it the medication to help with the Parkinson's symptoms that may be causing these symptoms? Lightheadedness or dizziness is another common symptom. Lightheadedness can again occur due to the disease itself or can occur from the medications. So all this is very important to differentiate when someone starts taking the medications. Did any of these start at that time that maybe that they may not be able to tolerate some of the medications that we are using? Swelling of the feet or pedal edema. The Parkinson's medications can cause it. Loss of activity, just sitting all day in a chair can also cause swelling of the feet. So again, important to differentiate, is it the medications doing it? Is it the disease doing it? Hallucinations, patients seeing things, imagining things, thinking someone is trying to hurt them. Again, the medications can do it, the disease can do it. So all these symptoms are very important, and we need to start off by trying to differentiate, is it the disease that is causing it? Is it the medication that causes it? And at times, even if we know that it is the medication causing it, trying to reduce the medication may end up causing more of the Parkinson symptoms, and we have to decide what may be the best in an individual on how we are going to use it. So if you look at the medication that we use for Parkinson's disease, and I'll go into a little bit more detail about these medications, the dopamine agonists, that's a group of drugs like Mirapex, Requip, Nupro, are the ones which are most likely to cause the side effects. And MAO-B inhibitors such as Selegiline, Rasagiline, or Azlect are the ones that are least likely to cause these side effects. So let's shift gears here a little bit and talk about quality of life. So why is quality of life important? Well, the reason is traditionally we have talked about disease states as an endpoint of mortality and morbidity. In other words, we used to say the number one cause of death is heart disease, the number two cause is cancer or whatever, cancer, strokes. So we used to look at the endpoint as what is causing death. Then we have turned around and looked at what is causing the most difficulty. Is it, again, heart disease? Is it cancer? Is it other things that are causing it? As we have done a better job of trying to manage some of these conditions, we are trying to look at other issues like actually quality of health. The quality of life is really important because that's what makes us feel what we are doing every day when we wake up in the morning, how we are going to go through the day. So not only is it important to reduce the mortality, reduce the morbidity, reduce the death and sickness, but equally important to maintain the quality of life of a patient so that they can function as good as they can. So what quality of life involves is a concept with a little bit of bigger range, looking at not only the physical part of the disease, but also the mental part of the disease. And there are a number of other issues that also come into play. For example, social support, socioeconomic status. I mean, how much money someone may have, that might be important to someone. Just the community that they are living in is important. Cultural differences, employment. So there are a lot of other issues that can also play a role in quality of life. But from our standpoint, we are also focusing a lot more on the physical and the mental aspects of the disease to improve the quality of life. There are a number of scales that are used to measure quality of life, and there are specific scales that are used in Parkinson's disease. The most common scale used in Parkinson's disease is what we call the PDQ-39, which has 39 questions. If you have seen me in the clinic, you have at least filled the PDQ-39 once in the time you have seen me. Some of the people have filled it more than once. Some of the people who are taking part of the NPF quality initiative have done it every year. And what that helps us do is actually follow the quality of life over years and kind of have a number that we can go back and look at it. And we would like to maintain the quality of life the same over the years or make it better. And when the quality of life begins to slip, we try to see what we can do to actually improve the quality of life. When we look at the questions the quality of life involves, it involves questions related to mobility. That's very important in Parkinson's disease. How well you can get up, how well you can move around. Activities of daily living, how well you can take care of yourself, whether it's riding, whether it's tying your shoelaces. These are important questions that are there. But quality of life also involves questions that has nothing to do with the physical part, more to do with the emotional part, the support part, the cognition part, the communication part. So if you look at it, a lot of the questions are related to the non-motor issues that affect the quality of life, not just the motor issues that are affecting the quality of life. And this is important because often when I talk to patients in the clinic, people are more focused on the tremor and slowness and forget that there are other things that are playing a very strong part in the quality of life. So someone's motor aspects may be only affecting 10% of it, but the emotional part may be affecting 90% of the quality of life. So until we answer that, the quality of life is not going to improve. So this was a study that was done in Europe. Patients newly diagnosed with Parkinson's disease, looking at their quality of life, again using the PDQ-39. So what they saw is when patients came into the clinic, the quality of life overall was affected about 20% or so. And over a period of 18 months, the quality of life kept getting worse and got to about 40% or so over that period of time. However, a group of patients just started their medications, or at any point they started their medications, and they found out over 18 months the quality of life stayed pretty even. It did not actually worsen. So if you look at it, technically that makes sense. You know, we are talking about Parkinson's disease as a progressive disease. If we do nothing about it, the symptoms will get worse over time, and the quality of life will worsen over time. However, if you treat it, then if nothing else, you can at least maintain the quality of life rather than making it worse. So this was giving you an idea of the total quality of life. But, like I mentioned, it has a lot of other subsections too. So if you break it as mobility, activities of daily living, emotional well-being, stigma, social support, cognition, communications, and bodily discomfort, again, with treatment, everything was maintained pretty well. However, if you were not treated, the quality of life in all these domains, not just the motor aspects of the disease, but also the non-motor aspects of the disease, kept getting worse. And that's why it is important to recognize these issues and treat these issues in a timely fashion to stay doing well. So if you look at it, from the questions and other things that we know of, what factors are affecting the quality of life? This morning, Peter brought up depression is a big issue. And the depression is the one which is also a very important issue that often patients are least likely to be willing to take medications for or see a social worker or a psychologist to help with it. But that impacts the quality of life, one of the most important features in Parkinson's disease. Memory issues. Once the memory issues begin, the quality of life definitely gets more and more difficult to manage. In general, other non-motor symptoms that may be present. Parkinson's disease itself, of course, affects the quality of life, the severity of the disease, the duration of the disease. Once patients who has been on medications for Parkinson's develops motor fluctuations and dyskinesias, that's the time when people take their Carbidopa, Levodopa, their symptoms are controlled, then the symptoms come back, they take another dose of the medication, so they start getting on these roller coasters, plus develop the involuntary movements or dyskinesias. That also significantly impacts quality of life. Falling, or just the fear of falling itself, can affect quality of life. Fatigue, and finally, caregiver burden. These are very important, and this is some of the factors that affect quality of life, not all the factors that can affect quality of life. So when we talk about treatment of Parkinson's disease, we are more and more focusing not only on the motor aspects of the disease, but also the non-motor aspect of the disease. And at times, improving the motor aspects can also improve the non-motor aspects of the disease too. So it's not always necessary to separately treat the non-motor aspects. Those may actually get better just improving the motor aspects. It's very important using physical therapy, speech therapy, occupational therapy, psychotherapy. These are very important part, and I think we often ignore using the therapists in our patients' care. The American Academy of Neurology recommends that these services should be offered to our Parkinson's patients at least once a year. So if your physician doesn't offer it, maybe once a year you need to bring up and say, you know, it's been a year since I've seen a therapist, maybe I need to go back just for a quick evaluation and have that redone. So when we talk about the treatment of Parkinson's disease, I'm going to see if I can play this. I'm going to just go over why we use these drugs and how do they work. So this is Levodopa. And anyone with Parkinson's disease is going to end up on Levodopa. This is blood flowing through the arteries. This is actually the chemical Levodopa, and along with it was the other chemical COMT. So what happens is Levodopa is absorbed into the blood. From there it goes into the brain, and we have just showing you one single cell in the brain. There will be multiple cells that are there in the brain. Once it goes into the brain, it is converted to dopamine. And dopamine is the chemical that is reduced in Parkinson's disease. And once that dopamine is formed in the cell, it is released and acts on the postsynaptic receptors. And here you see it's being released and goes back and acts there. Some of that goes right back and keeps being circulated. Some of it is metabolized or destroyed, and that's why you need more medication as the time goes on. So levodopa goes in the brain, is converted to dopamine, the chemical that is reduced in Parkinson's disease. We always use it with carbidopa, so you always have Sinemet or carbidopa levodopa. What carbidopa does is makes more levodopa go into the brain, so you can use less amount of levodopa and hence reduce the side effects that occur with levodopa. Pretty much every patient with Parkinson's disease get on levodopa at some stage of the disease. So it's one medication that if someone has Parkinson's disease, they will end up on levodopa, and it is the gold standard. It's been around for close to 50 years, and that is still our most important medication because that's the chemical that is reduced in the brain, and that's what we are supplying. It is available as different forms. The first part is the carbidopa, so here it's 10, 25, 1, 25, and the second part is the levodopa, 100 and 250. With slow-release carbidopa, levodopa, less levodopa is absorbed in the brain, so you have to use higher amounts. The other thing with control-release carbidopa, levodopa, at times it is not released consistently, and especially in the later stages of the disease, it may result in more dyskinesias than immediate-release carbidopa, levodopa. So the next group of drugs I'm showing you is MAO-B inhibitors. So how do MAO-B inhibitors work? Again, they are basically absorbed. So here again you have the blood. They go into the bloodstream, and here you have an MAO-B inhibitor here. From there, again, just like levodopa, it goes into the brain, and here it's going into the brain. And again, I'm showing you one single cell. The dopamine is still being released normally, and here is where an MAO-B is. So what it does is basically takes the dopamine that is being formed, and it reduces the metabolism of dopamine. So you have more dopamine, whether it's your own dopamine or dopamine from levodopa, which is around for a longer period of time. So that's how MAO-B inhibitors work. So we have two MAO-B inhibitors, selegiline and rasagiline. These drugs are basically keeping the dopamine around longer. I mentioned earlier, they have the fewest side effects of all the anti-Parkinson's medications we have. And they can be used early on by itself, basically to keep the own dopamine lasting longer, or later on with levodopa to keep the dopamine last longer from the levodopa that's there. We also have some data to suggest that may actually slow the clinical progression of the disease. That's why in early stages at times we may start it earlier with the idea about slowing the clinical progression of the disease. One of the issues that comes up with MAO-B inhibitors is that there's a caution, there's a warning about using MAO-B inhibitors with antidepressants. It's not a contraindication, it's a caution because at high enough doses, MAO-B inhibitors can also inhibit another enzyme, MAO-A, and using that with antidepressants can actually increase the chemical serotonin in the brain to very high, at times dangerous levels. In clinical practice, when we talk about MAO-B inhibitors, that's the only enzyme they're inhibiting is MAO-B. So the chance of having a reaction is extremely low. However, when you try to go fill your prescription, at times the pharmacist is going to look at the computer and going to say, oh, they're on an antidepressant, this is going to create a big issue, and they may either refuse to fill your prescription, or they'll call your physician to get an override on this interaction. There are certain medications that we cannot use with MAO-B inhibitors. These are certain narcotic pain medications, certain muscle relaxants, over-the-counter dextromethorphan, and St. John's wort. So there are other medications that you cannot use with it, but antidepressants can be used with MAO-B inhibitors. Let's move to the other group of drugs, the dopamine agonists. Now, dopamine agonists are a group of chemicals which act like dopamine. Again, let me show you here. So here again is the blood. Here you have the medication has made it from the stomach into the blood. From there, it will go into the brain, and here it's showing you getting into the brain. And when you go down to a single cell, unlike levodopa, which works here, unlike MAO-B inhibitors, it acts directly at the postsynaptic receptors. So they don't need to be converted into the brain. They do not reduce the metabolism of dopamine. They act directly at the postsynaptic receptors. And this is pretty much how dopamine agonists work in the brain. So we have three dopamine agonists. Nupro or rotigotine, which is a patch. That's only branded, it's not generic. And you have ropinirole or Requip, available both as a 3 times a day and once a day preparation. And Pramipaxol or Mirapex, also available as 3 times a day or once a day. They can be either used by themselves early on, or they can be used with levodopa later on to help prolong the duration of benefit with levodopa. Our concerns with agonists, especially in older patients, is the side effects. So they can cause sleepiness, they can cause swelling of the feet, they can cause certain impulse disorders. Patients can have uncontrolled gambling, uncontrolled shopping, uncontrolled eating, uncontrolled sex. So these are things that make us at times concerned. So when you come and we ask you about these issues, we are trying to make sure this does not happen. Well, in general, in the general population, you have about 2 to 3% risk of having one of these impulse disorders. In Parkinson's disease patients, it's a little bit higher. Patients who are taking Parkinson's medications like levodopa, it gets to be about 6 to 7%. And patients who are also taking an agonist, it gets to about 16, 17%. So you can see it just with Parkinson's disease, just with levodopa, but it is much higher with dopamine agonists. Finally, using COMT inhibitors. And so the COMT inhibitors act in the blood itself. So here again, I'm showing it to you, going it through the blood. And the way the COMT inhibitors work is they inhibit the enzyme COMT, which is right here. So they're acting, first of all, in the blood itself, and what that does is because levodopa is metabolized in the periphery, it keeps more levodopa getting in the brain, so you have more levodopa being converted in the brain to dopamine. The other way COMT also works in the brain itself too, and it also reduces the metabolism of levodopa in the brain. The thing with this COMT inhibitors, the one we most commonly use is entacapone, which is known as Compton, or along with levodopa called Stalevo. That mainly acts in the blood. It does not act in the brain. Another COMT inhibitor called tolcapone or Tasmar, which is hardly used in clinical practice anymore, does act both in the blood as well as in the brain. So it's basically, again, when you use it all together as one medication with carbidopa, levodopa, and entacapone, it is called Stalevo. By itself, it's called either entacapone or Compton, and tolcapone or Tasmar is the other one. It's always used with levodopa, so that's one thing with COMT inhibitors. You cannot use it by itself. You have to use it with levodopa because it's trying to extend the benefit of levodopa. A couple of other medications which are occasionally used in Parkinson's disease. One is amantadine. Amantadine is used more for involuntary movements, the dyskinesias. And anticholinergics like Artane and Cogentin are used much more in the younger patients where tremor is the predominant symptom. In older patients, it can cause significant side effects, so again, those are avoided. One medication that I did not mention is an injectable form of dopamine agonist called epomorphine. Epomorphine is used as a subcutaneous injection. It's a rescue therapy. It acts in about 5 to 10 minutes, and it lasts for about 60 to 75 minutes. And in patients who have random fluctuations, in other words, they are taking their medications on schedule, let's say, go to a restaurant, have a big steak dinner, medication stops working, they cannot walk back to the car, they can use an injection, it'll start working in 5-10 minutes, they can make it home, and by that time their next dose starts working. The other time we use rescue therapy is like early in the mornings. Some patients, it may take 2 hours to get going first thing in the morning. Again, using an injection, they can start moving around in 5-10 minutes and be able to do their morning work before the actual medications start working. Some of the other non-motor issues that we deal with, and the one to me that's the most challenging is the memory issues or dementia. Not only does it cause a lot of issues for the patient, but also the caregiver. We also know once the memory issues begin, the disease gets a little more challenging to manage. We also know patients can have other issues that come on once the memory issues begin. We may try to reduce the anti-Parkinson's medications, but we are only going to be successful up to an extent, because if we keep reducing it, then the physical part will get worse. And then we are trying to help more with the physical part rather than the mental part. There are certain medications called cholinesterase inhibitors, and they at times do help with the memory. So you have 3 of them. Exelon, Aricept, and Racidine. All these are available in generic form, so that's something to always consider if memory becomes an issue. Another one is Namenda, and that is still a branded drug, and it's approved for Alzheimer's, not for memory issues with Parkinson's disease, but at times it may be helpful even with memory issues with Parkinson's. Depression, we have brought this up multiple times. It's a very important part. It can significantly impair a patient's quality of life, and it's very important we treat them. We often use medications such as what we call SSRIs to increase the serotonin levels in the brain. We may use other group of medications in addition to SSRIs. Very rarely, if depression is a major issue, we may even have you talk to a psychiatrist about using ECT or shock therapy, because that can at times make a difference too in patients with severe depression. Often along with depression, anxiety can be an issue. It's equally important to treat the anxiety part. Often using medications for depressions like SSRIs may help with the anxiety, but occasionally we have to use medications like Ativan, which may also be required in certain patients. So those are other things to manage. Certain patients can develop a lot of anxiety, depression, memory issues when their Parkinson's medications are wearing off. So patients who are having motor fluctuations, when they take their medications, the physical symptoms improve, and when the medications wears off, the physical symptoms return. At the same time, their non-physical symptoms may also come up, so the anxiety, depression, memory issues may occur at that time. So keeping them as even as possible may not only help the motor symptoms, but also the non-motor symptoms. Psychosis, that is hallucinations or delusions, suspecting paranoia, all those are other issues can occur in patients with advanced disease. Treating it is, again, extremely important. Often these patients begin to have memory issues along with the psychosis. At times, patients with psychosis end up in nursing homes or long-term facilities because it may get very difficult to be managed at home. This is something that needs to be recognized. If someone is having just occasional hallucinations that are not bothersome, we may not treat it, but we need to be aware of it that these can get out of control. Again, reducing their Parkinson's medications may help initially, but again, people may pay a price of it that the Parkinson's symptoms could get worse. Nausea is one of the last non-motor symptoms that I'm going to kind of mention, because this can again occur due to the medications itself, and that can get challenging to manage because one cannot start Parkinson's medications because every time they take it, they may have some degree of nausea. In general, depending on the medication that is being taken, 10 to 15% of the patients when they're initiating anti-Parkinsonian medications may have some degree of nausea. This often resolves over days, if not over weeks and months. At times, we may use medications like plain Carbidopa to reduce the nausea, and at times we may use medications like domperidone. Domperidone is not approved in the United States, it's approved in Canada, but some local compounding pharmacies will use domperidone. Now what domperidone, it blocks dopamine in the periphery to reduce the nausea. It's okay as long as such a medication does not block dopamine in the brain, because that would result in more Parkinson's symptoms. The most commonly used dopamine blockers for nausea work on the brain and worsen Parkinson's. Domperidone is the only one that does not make it to the brain. And a couple of the rare ones are Tigaine and Vistaril are at times used to help with the nausea. Orthostatic hypotension or low blood pressure, especially on standing, where people may get dizzy, lightheaded, may at times develop some headaches. Again, the medications can do it, the disease can do it. If people are taking high blood pressure medications, often reducing some of the high blood pressure medications may help with the dizziness or lightheadedness. Keeping the head end of the bed up by 30 degrees at night may help. Using extra salt, fluids, or other things to consider. If a patient has anemia, that needs to be corrected. Wearing tight stockings will help. It's very uncomfortable. It's very difficult to put on. If it's easy to put on, then maybe it's not the right stocking, because you have to struggle to put on the stocking for it to actually work. Using caffeine, frequent small meals rather than large meals may be helpful. And often this happens after a large meal or rigorous exercise. So trying to cut down the exercise using it kind of, again, spreading it over time may also help with the blood pressure. Finally, if we need medications, we use medications like Florinef and Proamtine, which is fludrocortisone and midodrine. So Parkinson's disease, when you talk about it, the motor part, that's the tremor, the bradykinesia, the rigidity, the gait issues, the balance issues, the freezing is important, and it's important to treat those symptoms, but it's equally important to try to manage the non-motor symptoms, whether it's the depression, the anxiety, the memory issues, the low blood pressure, the nausea or constipation, because all those could also affect the quality of life in our patients. If we can keep those things in mind and also use therapists as needed, I think that will maintain the quality of life much longer. Patients who see me, I have your quality of life the first time you saw me. If you want to keep a check on it, you can ask me for the PDQ-39, and every time you come back, you can bring it, and we can tell you how you have done over months or years as far as your quality of life is concerned. With that, I'm going to open up to some questions if they are there. There are cards available around, and if you could fill those cards up for us, that'll be easier for us to take the questions, and hopefully we can take more questions that way.